Thank you very much. I have split it in two parts, and the first part will deal mostly with the SPECT MPI. So why is it important to lower the dose? Well, if you look in 2008, the media coverage of the issue of radiation dose, you will see that there was almost 2,000 times it was mentioned in the media, and mostly the message was it's dangerous, so dangerous that you have to be worried and to look for alternatives. That's the message from the media if you use radiation, so that's important. Now, if you look at the reality, the worldwide nuclear medicine volume, you can see that in SPECT worldwide, most of the radiation dose which is applied to patient goes for cardiology, and in PET it is mostly oncology. If you look in the US, you see that the nuclear cardiology part is even larger compared to the rest of the world, but it's mainly cardiac now in SPECT and it's oncology in PET. So we have to take care of this, and the question is how can we reduce it? This is just an overview of different points that I would like to touch upon. We can change tracers, and of course, if you do this, we have to think not only at SPECT, but of course also at PET. So this is one of the papers that Andrew Einstein has published on an overview on the radiation dose from different techniques. Invasive core angiography in the range of 7. If I look in daily routine, it's mostly over 10. But if you measure it in the papers, then it is sometimes somewhere there. Prospective triggering for the CT has brought down radiation. I'll talk about this in the second part. Now, if you talk about SPECT myocardial perfusion scanning, dual isotope is really rather high. Thallium is the problem here, and we have to go down to 1 day or 2 day protocol of stress only, or if possible, we change to PET, and there we have certainly lower radiation doses. So there is a possibility with the tracers, but then we also have to eventually change to other techniques. The other issue is that we can deliver lower doses and image longer. Now that is a little bit of a problem in elder patients who have back pain and start moving after a certain time. But what is the status quo? And I took here the guidelines of the European Association of Nuclear Medicine, telling us, for example, that in the 2 day protocol, most of the countries, and there is a heterogeneity because every country has its own laws, 750 to 1,000 megabecquerel, and in the 1 day protocol, we have to start with 350 plus, and then we repeat with a 3-fold increase in dose, and this gives you a range of 8 to 12 millisievert. That's the situation currently in Europe. And then if we look at the scan time currently, then we are between 13 and 23 minutes according to different detector techniques. That's about the range where we are. We can give less and scan even longer, but that is certainly not the main solution. We can use new reconstruction software, and I think that is certainly something which is rather helpful. We can shorten the scan time with new software. Iterative reconstruction is the keyword here, and there is from different vendors, and I put here the biggest ones. From Philips it's called Astonish, from Siemens it's called Flash, and from GE this development is called Evolution. There is new software which has shortened the acquisition time. And these are new iterative reconstruction algorithms which are mostly very much specific to the geometry of the intrinsic system and collimator geometry, and it's called collimator detector response, certainly specific to models and different vendors. And there is resolution recovery, and it has been primarily validated for bone scans and then thereafter also for cardiac scans, and then in general purpose gamma cameras. They are using the comparison then, I mean the classic one was FPP, filtered back projection, which originally has been borrowed from the CT reconstruction and had been utilized more than 25 years, and it certainly is a standard, but iterative reconstruction is now getting more and more into daily routine. We are exclusively using this for cardiac. Resolution recovery requires much less data input, and that's exactly what we want. We give less dose, and so we have much less data input. We can hopefully do it with half of the projections, half of the time, therefore, and at the end half of the dose. There is, however, ongoing research because these algorithms can be improved. We have validated one of those, which is the Evolution for cardiac. We took a dedicated cardiac camera, this one here, which you see here, a Ventri gamma camera, and we have validated a 1 day stress protocol on this camera. The vendor says if you scan standard, then you have a 25 seconds scan time per frame per angle, and then with the half with the half time acquisition, you would expect to be double the speed because it's half of them, but it's only half per angle. But the rotation time of the detector is okay, of course, the same. So at the end, you end up not having just half of the time, but just a little bit less. Still, it is shorter. We have validated this in a series of patients and found this is just one example that we find in general identical clinical information. Here it's a mild reversible defect, so it works well. If you look at the correlation and the blend Altman limits of agreement for the segmental uptake, you really find that it is within the rescan repeatability of nuclear scans. Even the ejection fraction, even though we use 16 bins, we have a very good correlation and acceptable limits of agreement. That's one aspect, reconstruction with the software, but we can also use faster cameras. And I think there we are getting into a new field, which is quite interesting. So the old classic gamma camera is a sodium iodine detector, which is rather a big thing here with a photomultiplier behind here. Now the new detectors, semiconductor detectors, they're tiny bits, and because they're so tiny, you can put them put them around the body because they're much smaller, and so you can cover half of the chest easily. And so these detectors now, in some of the models, acquire all the pictures, all the angles at the same time. So instead of having detectors which move and then stop and shoot for about 20 minutes, you just acquire all the angles at the same time. And that is certainly a big advantage. You have no detector motion, it's focused on the heart, and it's a compact design, making it also smaller. I show you just one of those here. This is one of it's a SPECT camera here. Quite an elegant design, to be honest. I went there and did sit myself in one of those. Looks comfortable, but every coin has two faces. It looks a bit less comfortable from this side, you know. But however, it's a nice camera, not so uncomfortable, and certainly no claustrophobia can happen here. So this is certainly an aspect, and you find a place in all cardiologist offices. And in fact, since in the US cardiologists were allowed to start nuclear cardiology, there was an explosion of scans because they can now bill it, and that's one aspect of medicine. And they claim that this camera has about a 10 times higher system sensitivity. And when I saw this, I thought, wow, this is the future. And I started learning a little bit about these new detectors. And I realized that the gain in speed is not due to the fact that these detectors are 10 times more sensitive. Not at all. It's the fact that they don't have to turn around the body and you cover all the angle at the same time. And you end up being much faster with your detector geometry. And there are different ones. There is this one from SPECT where the detectors still change a little bit their angle. There are about, I think, 9 solid state detectors up here, they say. And so you still have a little bit of angle movement. But still 2-minute clinical studies, I think that's impressive. We opted for the other one. That's a GE scanner with the crystals of the CZT, not crystals, but detectors down here. This is the classic camera. We put it side by side because we put every patient who came here, we put him then here. And you see how small the camera is. There is no claustrophobia neither because it's a very small gantry. Interesting part of it is you can acquire list mode files. It's pretty much like in PET. And we looked at how short we can scan. We scanned the patient and then subtracted by cutting off the list mode file, and so how short we can be. And this is the result. When you cut the time down, even down to 1 minute duration, we found exactly the same pictures as with the classic Ventri 15-minute scan time. So that's pretty quick, and you can now argue that you can lower the dose by a factor of 15, or if you care for elder patients, maybe you want to cut the radiation only by 3-fold and then 5-fold time cut, so you can reduce your speed, you can reduce your dose, or you can increase the speed according to the needs of the specific patient situation. We were looking, because we were the first one using it and apparently looking systematically at it, we were looking how fast you really can scan to be systematically consistent, and we looked at the acquisition time with high and low dose, and we figured out that the clinical agreement and the correlation of tracer does not improve any further after 2 minutes with the high dose and after 3 minutes with the low dose of the one-day protocol. So we figured that a couple of minutes really is enough to scan with these patients, and we have published the protocols here. We have also validated it against a classic conventional spec to see whether we have a good agreement, and the agreement was really excellent. So we were comparing perfusion versus perfusion here, and we have validated this in another protocol. We were also looking for the issue, and maybe I was a bit too quick here, we were hoping really that with this technique we would probably avoid some of the attenuation problems, because we have a pinhole system and it is all focused and centered on the heart, and we were hoping that the abdominal issues of tissue attenuation would not happen, but still it happens, and attenuation correction with the CT is still helpful. However, there is another trick you can play here. You can tell the patient to breathe in, hold the breath, and then you scan for 10 seconds, and then you stop and start again, and if you do this 12 times you have 2 minutes. And that's what we did. We tell them breathe in, hold your breath, and at the end we merge the file, and then we get these pictures. On the left side you see the Ventri picture of an obese patient, and on the right side a CZT gamma camera, Cadmium Zinc Telluride. That's the polar map. The inferior part most probably is due to tissue attenuation. If, however, you do a breath hold inspiration scan, you will see that the angle between the inferior wall and the diaphragm is massively increased, and as a result you find almost no attenuation down here, and that indicates that this is attenuation and not a true perfusion abnormality. And you can do this with you can do that quickly, because the acquisition time is relatively short. Most patients can hold the breath for 10 seconds, and you can repeat that 12 times. If you would gate the breath, you would not end up with these results, because usually it's not a deep inspiration breath that it would be shallow breathing. That would not make the same, most probably. That's why we did deep inspiration breath hold. We have validated this and also published the protocol. We have thought to shorten the protocol time, which means shortening scan time plus shortening the protocol time. Now, this is the classic protocol time, which includes how long are you in the department. We give adenosine, we inject technetium, we wait for decrease of the GIT activity, and then we do a standard stress acquisition. Usually that was about 15 minutes, and then we wait, we inject then the rest, and then we wait to decrease the GIT activity. We do stress-rest sequence, because if stress is normal, we don't do the rest, and then we do the standard acquisition. The whole protocol is about 2 hours and 30 minutes for the whole protocol. That's pretty long, and you can of course shorten it if you are trying to save time wherever you do that. We do that, if you compare it to here, we did what we do with these patients, what we have borrowed from Giorgetti. He is not waiting after the injection of the rest. He is just scanning straight away, and that shortens the scan time and the protocol time, because you're not waiting. Particularly the protocol time is of course shortened to 1 hour and 18. And what we do if we do stress, not pharmacologic but bicycle stress, we put the patient immediately on the camera, and then we scan the stress, and then we inject the rest, and 2 minutes later we scan the rest. So we are really compacting this very much. Every patient has a 30-minute slot on the camera, so he gets there after having gotten the injection for the stress. He gets the scan, 5 minutes. We do 5 instead of 2 because we think that's a safety margin, and then we inject the rest and we scan 5 minutes rest. So it's a very compressed protocol, and that's 50 minutes with bicycles. So we have better image quality with bicycles because we have no GIT activity, and it's quick and it's very accurate. What we found out, we have compared to invasive coronary angiography, and we have compared to standard nuclear perfusion, and it turns out that this protocol is valid and works very well. However, there is even more behind these new cameras. If you want to have if you want to take the most advantage out of it, you can do what we call low dose one-day protocol. Now, what does that mean? It means the following. If you have a CZT detector technique, the linearity between the counts in the body and the counts that you get on the camera is 1-to-1. You have more counts, you have that factor more counts on your camera. With the old cameras, with the standard cameras, it runs off. There is a roll-off of this linearity. There is no linearity. The incident count rate that you measure from the ones which you have in the source in the heart was flattening off. Now you have a one-to-one linearity, which means after having done the first scan, which in our case is the stress scan, I do not have to give 3 times higher dose. I can give the exactly same dose and I can subtract the background that I have in the heart because it's one-to-one, it's linear. I know exactly how much it is. And that's what we did in this study. We injected the patients after stressing them and doing some attenuation correction CT. We did an acquisition of the stress. And then 2 minutes later, we injected the low dose, 320, like for the stress, 320, and we scanned them. And then to assure in this validation phase that the patient gets a standard scan, we added the rest of the dose to have 3-fold increase compared to stress, so that we have now 2 rest scans, one with the low dose and one with the standard dose, which is 3 times higher in total than at stress at the first part. This is some biographics based on characteristics. Here what you can see is with subtraction, we have in the majority of patients 0 difference of the sum stress score and between of the sum stress score, and we have almost all within -1 and -2 +2, which is very much within the retest accuracy of this scan. Without subtraction, we have a very broad values. If you look at the pictures, this is one of the examples. Rest with low dose, rest with standard dose, which is done 2 minutes after the stress injection. We just subtract what we found before, and we have a perfect reversibility, partial reversibility. In fact, if we measure the extent of the defect at stress, and then we measure the extent of the defect at rest and the reversibility, that's the main concern, that you miss the reversibility if you give a low dose. The reversibility was almost exactly the same with the low dose than with the standard dose. So with this protocol, we could show that we can quantitatively subtract the first scan and do a low dose 1-day protocol, which saves you 50% of the dose. Of course, you can do stress only. I think that's a very important part also of our daily business. We should have a look at the scan and then decide whether we need to do a rest or we do not need to do that. We can do attenuation correction, and we should compare it with prior studies. If you have a patient who has had a study previously and he had a normal scan or he had a defect already, why not having a look at that old rest scan and then see whether there is any difference? If there is no difference at stress to the rest scan from 5 years ago, there is no way that we need another rest scan. So we really try to minimize the need for a rest scan, which in our case is the second one. That's why the sequence stress rest is the best sequence, because we can omit then the rest if not needed. Finally, with this part of my talk, there are nuclear alternatives. And you might be surprised, but a couple of years ago when I started in nuclear medicine, the boss of nuclear medicine in Zurich was also the boss of the nuclear magnetic resonance imaging, because that's also nuclear. We do have nuclear alternatives, and I would like to show you here a hybrid picture done with stress, technetium, tetraphosphine plus CT angiography, a total of 3.5 millisievert. I would say this is quite a low number of radiation dose already, but you can do this even better. And we did it with 1 millisievert in the same patient, and you can see that we have not missed the perfusion abnormality which was stress-induced. How did we do it? We used nuclear magnetic resonance imaging. So it's a CMR-CT combination hybrid picture. The novelty here is that usually with the MR you get 3 slices, so you miss 60% of your heart. But here we use a sequence which allows us to see the whole heart. Maybe I can make the movie run. So this is the CT angio, obviously, and you will see with the colors the blood, the contrast material in MR flowing in, covering the whole heart, because we have a new MR sequence developed in our institution which covers the whole heart instead of just 3 slices, and you can now nicely produce nuclear magnetic resonance imaging hybrid pictures like this, showing here the lesion with the ischemia nicely in this area. I think we have to consider at least the nuclear alternatives, because it is a true alternative. It has been, this has been published on the cover of the European Heart Journal because it has raised some interest in the cardiology world. In summary, we can change tracers, but then you have to go towards PET. We can apply lower doses. We would then have to image longer, which may not be feasible with some of the patients. We have to consider new reconstruction software, And certainly this is a must. This has to be implemented. We can use faster cameras. I recommend if you have a big cardiac volume SPECT, then think of one of those dedicated cameras. We can and should do stress only wherever applicable. If we do attenuation correction, we get rid of most of the attenuation artifacts, and then we don't need a rest to reassure that we don't have any ischemia. We can compare with the prior studies, and also we should consider that we have nuclear alternatives. It's not the enemy. We have to know that this works also quite well, and in the future it will work even better because there are new sequences coming up. Then of course, there will be need of validation studies, and we are trying to do this. One of those studies, and many of these studies are running in the meantime.